I would like to start the first session by inviting our two moderators, Dr. Rushma Tandon and Dr. Vibhakar Advaryu, to come over and start with the session. The sessions have been divided into 4 sessions. One is a session with basic knowledge. Session 2 is a session primarily on back pain and associated problems. Session 3 is a problem on neck pain and more exotic spinal conditions. And Spine 4 is current management issues associated with back problems. So without much ado, Dr. Rushma, Dr. Advaryu, I would be grateful if you would.
Good morning, Gautam. Thank you so much for inviting us to moderate this session. My co-moderator for this session is Dr. Vibhakar Advaryu. Good morning, sir. Sir, you'll have to unmute yourself. Dr. Vibhakar, please unmute yourself. So the Masters of the Association of Spine Surgeons of India have put together a master class in spinal problems for all the physicians out there. And with my co-moderator, I would like to invite Gurdip Das, the first speaker of this Sunday session, who is going to speak on spinal anatomy and function. Spinal anatomy and function is a very important part, and this is where we begin from. And as we build up on this session today, I'm sure it's going to be very interesting. Dr. Gurdip?
Rupesh, can you play Dr. Gurdip's talk?
Respected Chairperson and my dear friends, a warm good morning to everyone. I have been asked to speak on spinal anatomy and function, and I hope that my presentation is going to help you in the upcoming lectures. When you talk of spinal anatomy, the spine is divided into 5 basic segments. These are the cervical, thoracic, lumbar, sacrum, and the coccyx. But the basic unit of each of them is the bone called as the vertebra. And the cervical has 7, thoracic 12, lumbar 5, sacral 5, and the coccyx has 4 vertebrae. These vertebrae are arranged in such a fashion that the cervical and the lumbar are arranged in lordotic alignment, whereas the thoracic spine is arranged in kyphotic alignment. And each of these vertebrae are little different from each other in the corresponding segments. Now I'm going to touch upon these in the upcoming slides. The first segment is the cervical spine. It is known for the great deal of motion that it allows. The cervical vertebrae are 7 in number and they are slightly smaller than the other areas. The first cervical vertebra is called as the atlas. The second is called as the axis. The third to 7 are called as the typical cervical vertebra. These vertebrae are arranged in this manner in the cervical spine. Please note the bifid spinous processes. The first cervical vertebra does not have a body, neither does it have a true spinous process, and it basically functions to support the weight of the skull through the atlanto-occipital joint. This joint contributes to almost 50% of the overall flexion and extension of the cervical spine. The second cervical vertebra, called as the axis, has a small body, and it also has a small peg-like projection superiorly called as the dens. It has a bifid spinous process, and with the first cervical vertebra, it forms the C1, C2 or the atlanto-axial joint. This joint contributes to almost 50% of the overall neck rotation. The third to 7th vertebra are called the typical cervical vertebra. They have bifid spinous process, and their transverse processes have a foramen called as the foramen transversarium. The cervical spine is stabilized by multiple ligaments, and these include the anterior longitudinal ligament, the posterior longitudinal ligament, the ligamentum flavum, the interspinous ligament, and the supraspinous ligament. These ligaments are also there in the thoracic and the lumbar spine and contribute to the overall spine stability. The ligamentum flavum is a very important structure in the spine, and because it covers the neural sac and the spinal cord and acts as a protective layer. It consists of 2 layers, the superficial and the deep, and it origins from this halfway of the lamina superiorly and inserts into the superior aspect of the caudal lamina. The vertebrae are arranged in this manner. It has a vertebral body and the central spinal canal, and the lamina and the spinous process posteriorly. The large central spinal canal contains the spinal cord, and from it arises the nerve roots. The nerve roots in different areas of the spine supplies different muscles. The cervical nerve root supplies the upper limb, whereas the lumbar nerve root supplies the lower limb. The cervical nerve roots also supply a particular group of muscles. For example, the 5th cervical nerve root supplies shoulder abduction, the 7th cervical nerve root supplies elbow extension, the C8 and the T1 nerve roots supply the finger group of muscles. These nerve roots are arranged in a very peculiar manner with respect to the vertebral body. For example, there are 8 cervical nerve roots but 7 cervical vertebra, and each named nerve root passes above the level of the corresponding vertebra. To just make it simpler, the 5th cervical nerve root passes above the level of the 5th cervical vertebra, and the 7th cervical nerve root passes above the 7th cervical vertebra. Now, the cervical spine allows a good deal of movement. So, it allows almost 45 degrees of flexion and extension, and around 80 degrees of rotation on either side, and around 45 degrees of lateral bending. To summarize this all, the cervical spine is known by its bifid spinous process, which is present from the 2nd to the 6th cervical vertebra, by the presence of a transverse foramen, which is there from the 1st to the 7th cervical vertebra. This is occupied by the vertebral artery from the 1st to the 6th cervical vertebra. The occiput C1 joint contributes to almost 50% of the neck flexion extension, and the C1, C2 joint contributes to almost 50% of the rotation in the cervical spine. The next segment of the spine is called as the thoracic vertebra. These are 12 in number, and they are heart-separated structures. They have long spinous processes which are inclined downwards, and they have prominent transverse process with costal facets. These articulate with the ribs. The facet joints are oriented in the coronal plane, which limits their forward bending. The lumbar vertebras are 5 in number, and they include the 1st to the 5th lumbar vertebra. They have short stout pedicles with thick, broad lamina and short, broad spinous processes. They have thick, tapered transverse processes. The facet joints are oriented in the sagittal plane. In between two vertebral body lies the intervertebral disc. This acts as a shock absorber in the spine. They consist of the nucleus pulposus and the peripherally located annulus fibrosus and the cartilaginous end plate. This composition of the nucleus pulposus is a little different from the annulus fibrosus. The nucleus pulposus is a juicy, fleshy structure and consists of almost 85% water. The annulus fibrosus is a little tougher, thicker, and it consists of 60% of type 2 and 40% of type 1 collagen, in addition to the water and proteoglycan composition. In the spinal canal lies the dural sac. The spinal canal is an oval structure, and it can be divided into 3 zones: the central spinal canal, the lateral recess, and the intervertebral foramen laterally. The dural sac occupies the central canal. Between the dural sac and the pedicle or the intervertebral foramen lies the lateral recess. The lateral recess is a very important structure to be noted because this is where the nerve roots lie in the lumbar spine. After coming out from the dural sac, the lumbar nerve root travels a few distance within the spinal canal before it goes into the intervertebral foramen. And here, if the ligamentum flavum hypertrophies, the nerve root can get compressed. The lumbar nerve root orientation and arrangement is slightly different from the cervical spine. We discussed earlier that the cervical nerve roots lie above the corresponding body or pedicle. That is, the 6th cervical nerve root lies above the 6th cervical pedicle. But in lumbar spine, it is different. The L4 nerve root lies below the L4 pedicle. The L5 nerve root lies below the L5 pedicle. The S1 nerve root lies below the S1 pedicle. This has to be noted when you are correlating the clinical findings with the MRI findings. The intervertebral foramen is a very important structure. This is where the nerve root lies after coming out from the lateral recess, and it is a keyhole shaped structure in which the nerve root occupies the superior portion. The Presence of transforaminal ligament limits the mobility of the exiting nerve roots. So if there is a disc herniation in the intervertebral foramen, the nerve roots may get pinched and you can have severe radicular pain. The lumbar nerve roots supply the muscles of the lower limb. For example, the L3 nerve root supplies the knee extension, the L4 nerve root the ankle dorsiflexion, and the L5 nerve root the great toe extensor. The muscles of the lumbar spine are broadly divided into intrinsic and the extrinsic group. The intrinsic group includes the erector spinae and the multifidus, whereas the extrinsic group includes the abdominal and the posterior thigh muscles. The erector spinae is a very important muscle that has to be noted and studied. The lumbar spine movements are mainly in the flexion extension and in the lateral bending. Because of the presence of sagittally oriented facets, rotation is not greatly possible in the lumbar spine. The sacrum is the fourth segment of the spine. It consists of 5 fused sacral vertebra, and it consists of a smooth concave ventral surface and a rough convex dorsal surface with foramina. Through these foramina pass the sacral nerve roots, which control the bladder and bowel function. The last segment of the spine is called as the coccyx. It consists of vestigial vertebrae called from the first to the fourth coccygeal vertebra. And this is also called as the tailbone. And on top of this, you sit. With this, we come to the conclusion of my presentation. I hope you enjoyed it, and you will probably collect these findings when you are going through the other lectures. Thank you.
Thank you, Dr. Gurdip Das, for starting the ball rolling to build up a very good innings of the day. We have now known the basic anatomy of the spine, and from here we move on to clinical evaluation of the spine. And this lecture will be delivered by Dr. Jwalant Patel. Dr. Jwalant Patel, please.
Very good morning to everyone. I will be talking about how to clinically evaluate the spine patient. Clinical examination actually starts as early as patient enters the door of the OPD. That is followed by comprehensive and detailed history taking and thorough local and systemic examination that will help you to reach 3 or 4 provisional diagnoses at the end of history and examination. Why clinical examination is important? We will understand it through the few case examples. Look at this case scenario 1. 48-year-old female patient with uncontrolled diabetes presented with chronic neck pain and bilateral shoulder pain. However, the upper limb tingling and numbness were the only finding on clinical examination, and rest of the neurology was normal. And surgeon has decided to do 2-level anterior cervical discectomy and fusion. However, the shoulder pain was not relieved and patient was worried about, and she was ultimately diagnosed with rotator cuff tear. So lesson to learn here is to rule out the extra spine etiology in each and every patient before jumping onto the surgical intervention. Most of the spine patient with the spine pathology present with either pain, neurological deficit, neurological claudication, deformity, stiffness, swelling, or other constitutional symptoms. So it is very, very important to understand the basic chronology. That means the which symptoms are most troublesome to the patient is very, very important. By far, the pain is the most common symptom patient complain about, and it is important to understand the basic characteristics of the pain, like onset of pain, whether it is an acute or insidious onset, timing of pain, whether it's a night pain or activity related pain, the exact site of pain, the nature of pain, whether it is a stabbing pain like in disc herniation, it's a continuous throbbing pain, infection, it's a dull aching pain like in tuberculosis, the exact radiation of the pain that will help you to identify the exact nerve root involvement when the pain is specifically located in a specific dermatome. Whether the pain is associated with the morning stiffness and the raised stiffness like in ankylosing spondylitis and other spondyloarthropathy. It is important to elicit the pain aggravating and relieving factor like the pain associated with the disc herniation increase with the forward bending, coughing, sneezing and turning in bed, while the backward bending will increase the pain of lumbar canal stenosis, facet arthritis and spondylolisthesis. It is important to note the walking distance. Make the patient walk into your OPD. And sometimes few neurological signs that are not obvious on static position that will be manifested after some brisk walking in the OPD. So it is important to note the walking distance in lumbar canal stenosis patient. It is the table showing differentiating features between the neurological claudication and vascular claudication. All of you know that the pain of vascular claudication increases with the stair climbing and cycling. However, the pain of the neurogenic claudication reduces. And it is important to feel the distal pulses in each and every patient. After history taking comes the role of clinical evaluation, and that comes with that start with the general examination of the patient from head to toe with full exposure of the patient in adequate light. Also try to note the weight and height of the patient at frequent follow-up intervals. Sometimes the neurocutaneous markers like capsuloid spots, hairy patch, ligament laxity, clubbing, lymphadenopathy, all these are the systemic and the general manifestation of underlying major pathology that should be recognized early to detect the underlying disease. Also try to note the gait and attitude of the patient, how patients stand and walk into the OPD, whether it is unassisted or the assisted walk with one stick, two stick, or the walker. It is a video demonstration of patient with cervical myelopathy that walks with a myelopathic gait. Also try to inspect the patient from front, side, and back in standing, supine, and sitting position. Also try to note the alignment of the patient and normal curvature of the spine. Sometimes patient present with a functional scoliosis that is present in standing position due to the disc herniation and paraspinal muscle spasm. However, it will disappear in sitting and supine position. However, the structural scoliosis will persist even on standing, sitting, and lying down position. It is called as the Adams stage. Also try to note the shoulder and pelvis level, whether they are tilting towards the one side. Also try to note the neck and scapula, not the lower posterior hairline, webbing of the neck, high riding scapula. All these are the manifestation of underlying syndromic condition like Cleveland syndrome, Marfan syndrome, or the Sprengel shoulder. Also try to look and palpate the swelling, whether it's present in the neck region or the flank region. It can be a cold abscess with underlying spine tuberculosis. Also note the rib hump and midline swelling that is manifestation of spina bifida. Also try to evaluate the attitude and deformity of the upper limb and lower limb that is due to the muscle spasm and atrophy. After inspection, all your inspected finding must be confirmed with a palpation. Try to evaluate the local skin temperature and paraspinal muscle spasm and tenderness. The basic understanding of normal bony landmark will help you to identify and localize the exact level of vertebral pathology. Try to evaluate the soft tissue and deformity. It is very important to elicit the normal range of movement of the various regions of the spine like cervical, dorsal, and lumbar. That will help you to identify the early detection of some of the spondyloarthropathy like rheumatoid arthritis and ankylosing spondylitis. There are certain special tests available for the cervical spine like Sperling maneuver that is 90% specific for the acute cervical disc herniation leading to the cervical radiculopathy. However, the pain of cervical radiculopathy will reduce with cervical dissection test and shoulder abduction sign. There are certain special tests available for the lumbar spine like SLR. However, you must remember that the SLR is considered positive for acute disc herniation only between the angle of 35 degree to 70 degree. However, you can again confirm it with a Boston test and sudden sciatic stress test. Look at this case scenario 2. 58-year-old female patient with a chronic low back pain since many years and bilateral radiculopathy, which is more on the left side. However, the rest of the neurology is normal and surgeon has decided to perform a fusion surgery. However, her back pain is still persistent and ultimately she was diagnosed to have a rheumatoid arthritis along with the SI joint, sacroiliac joint fused. So lesson here to learn is don't forget sacroiliac joint and other arthropathy involvement. There are certain specific tests available for the sacroiliac joint pathology like Faber test, figure of 4 test, Pump-Handel test, sacral thrust test, and 2 positive tests out of 4 will give you 88% sensitivity and 78% specificity. Look at the case scenario 3. 73-year-old male patient with a chronic neck pain which is worsening since past few months. However, the hyperreflexia was the only positive subtle sign on examination, and physician has decided to treat this patient with the physiotherapy and traction. However, after 1 month, patient has developed quadriparesis. So lesson here learned is to detailed neurological examination is very, very important. That consists of motor function, sensory function, reflex evaluation, visceral function, involuntary movements, and gait. The basic understanding of particular myotome, that means the specific group of muscles supplied by specific spine cord segments in upper limb and lower limb that are most commonly involved, is very, very important. That will help you to identify exactly, localize the level of lesion. Also, the specific dermatomal pattern of pain and sensory involvement help you to identify the exact level of spinal cord segment affected in upper limb and lower limb. It is very important to elicit the deep tendon reflexes, and always compare it with the opposite side. Also try to elicit the superficial reflexes like superficial abdominal reflex, Babinski reflex, Hoffman sign, and inverted supinator jerk. To conclude the examination and rule out the extra spine etiologies, it is very, very important to perform shoulder examination, hip and knee examination, peripheral nerves, brachial plexus, and thoracic outlet. There are certain simple tests and signs that you can perform in your day-to-day practice in OPD that to evaluate the extra spine etiology. Also, always must feel and palpate the disturbances, and rectal examination is must in trauma patient. Just to conclude, history and clinical examination are the eternal part of practice that should be detailed and comprehensive, that will help you to reach up to the provisional diagnosis and help you to rule out the extra spine causes. However, before jumping on to the surgical intervention, clinico-radiological correlation is must, and must. I would like to thank ASSN and organizing committee for this opportunity. Thank you.
Thank you so much, Jwalant. I think that was a very, very good lecture. And the way you have pointed out with case presentations and clinical correlation to explain what all should be examined clinically was very apt. Thank you once again. We would now move on to the next lecture, and I would like to invite my friend Hitesh Modi to give his talk on X-rays and imaging in back pain.
Hello, I am Dr. Hitesh Modi from Ahmedabad. We are going to understand about spine X-rays in a simplified way. Let us start with a case of 38-year-old male who has been suffering from chronic upper dorsal back pain and showed to local physicians without any significant findings and outcome. However, upon development of occasional mild imbalance, we got an X-ray, and if we pay a closer attention to the X-ray, we can see that there is a spondylolysis as well as decreased and irregularities of the intervertebral disc in AP and lateral film, suggestive of an associated infection. Therefore, we must pay a closer attention and very important attention to the X-ray in identifying spine pathologies. Whom should we get a spine X-ray? It is the first line of investigations of patients of having spine problem and associated neurological problem, which can be helpful in diagnosing a variety of spinal conditions. So, we should normally get an AP and lateral films as a first line of investigations. If we suspect instability, lateral flexion extension view is also advisable. Open mouth view or swimmer's view is also important in craniocervical and cervicothoracic pathologies respectively. In lumbar spine, oblique films to identify foraminal pathologies and bending films for scoliotic conditions are also helpful. Standing and weight-bearing X-rays are more helpful than supine films. Normal cervical spine shows a straight line with spinous processes in midline and lateral masses and uncovertebral joints in AP films. While lateral films, it shows a normal lordosis with symmetrical disc height and facet joints at all the levels. Anterior prevertebral shadow reflects a tracheal line. If we see a normal cervical lordosis obliteration, which shown here suggests muscle spasm, or decrease in the disc height will suggest disc degeneration or disc herniation. Lateral flexion extension views also will be helpful to identify instability in cervical spine. Here, it shows the fracture displacement with kyphosis development due to instability on flexion and extension views. If we see increase in distance between C1 and C2, which is known as atlantoaxial distance or C1-C2 distance, It is important to identify C1, C2 subluxation and it needs a surgical attention. If patient having C2 dense fracture, controlled flexion extension view is important to identify instability like in this closure view. If we see increased distance between posterior spinous process, it may indicate associated instability. Open mouth view of cervical spine normally shows symmetrical distance between C1 and C2 as well as C1 and C2 joints with normal structure. If there is an associated arthritis, dense fracture or rotatory subluxation like suggestive of here, open mouth view carries a lot of importance. Fusion of all vertebrae anteriorly and posteriorly indicates ankylosing spondylitis. In trauma cases, it may indicate fracture. Thoracic and lumbar spine X-rays. If we see a normal lumbar spine X-ray suggests midline spinous processes with symmetrical pedicles in all images and smooth lordosis with maintained disc height in lateral images. Normal epifilm should contain 12th rib as well as hip joint. In thoracic spine, it suggests similar finding in epifilms as well as smooth dorsal kyphosis in lateral films with symmetrical pedicles. If we see scoliotic tilt with obliteration of lumbar lordosis, it can suggest muscle spasm or maybe disc herniation associated with nerve root compression. Decrease in disc height compared with the level above indicates disc degeneration or herniation. If we suspect instability in patients with chronic mechanical pain, flexion extension views should be carried out. If we see a significant forward movement of one vertebra over another, it can suggest instability. We may also see fracture in vertebral bodies, and if interpedicular distance is increased compared to above and below, it may indicate burst fracture, while if not, then it may indicate compression fracture. Complete dissociation between spinal column suggests fracture dislocation, or movement compared to the vertebra above suggests fracture subluxation. Standing whole spine films are important to see pediatric scoliosis deformity or a kyphotic deformity. If it is in case of elderly, it is degenerative scoliosis. If there is an incomplete formation of vertebra shown here causing kyphosis or scoliosis deformity, it is a congenital hemivertebra. If there is a fusion of cervical spine at single or multiple level, it is known as Klippel-Feil syndrome or abnormal fusion of cervical vertebra. A defect in pars interarticularis is also known as spondylolysis. It is typically seen as a Scottish dog appearance on oblique film X-rays. If a spondylolysis is associated with the forward movement of one vertebra over the another vertebra, it is known as spondylolisthesis, and in such cases, a flexion extension view carries a lot of importance. In elderly, if there is no lysis but significant listhesis, it is known as degenerative spondylolisthesis. Degenerative scoliosis is seen with pedicle rotation with curvature of spine or may be associated with the spondylolisthesis. If we see disc narrowing with lysis of vertebral body, it may be associated with spondylodiscitis as shown in this MRI. Sometimes collapse of vertebral body with dissolution of disc height may be associated with significant infection with abscess formation in paravertebral structures as well. It is indicative of infection like Cox or bacterial infection. Patients having chronic back pain with small compression and associated lucency suggestive of non-union in compression fracture, which is also known as a vacuum phenomena. Occasionally, We must investigate in form of MRI if we see disc degeneration or decrease in disc height on X-ray with severe back pain to differentiate it with disc degeneration versus infection. Multiple vertebral bodies opacity in AP and lateral films often indicate metastatic spine from unknown primaries. If we see non-traumatic compression fractures at multiple levels in spine, it may indicate metastasis, or if we see a symmetrical appearance of pedicle which is absent at one level, which is known as winking all sign, it is indicative of malignant lesion of the spine. This is again an example of winking all sign, and it is indicative of primary malignant lesion, and MRI or PET scan is indicative. This is again an example of winking all sign with osteolytic vertebra of L3, suggestive of malignant lesion of the L3 vertebra. If we see fusion of all vertebra and disc in AP and lateral films with sacroiliac fusion, suggestive of ankylosing spondylitis or bamboo spine. Radio-opaque vertebra or increased density with fusion of vertebrae will indicate fluorotic spine, such is shown in this X-ray. Thank you all for patientful hearing, and I hope this will clear a lot of doubts of spine X-rays. Thank you again.
Thank you, Dr. Hitesh Modi. X-ray is the basic of all imaging modalities, and you have dwelt into the basic of the spine. To know more about the soft tissues, we need to go into further imaging modality where the MRI is very important. And to tell us more about the MRI of the spine, we have Dr. Ravish Patel to tell us. Dr. Ravish Patel, please.
Good morning, everybody. Let me start my today's talk with this case. A 45-year-old female who was having difficulty in walking and bilateral lower limb pain, which was not getting better with conservative care, came with this lumbar spine MRI done elsewhere, and she was awaiting a lumbar spine surgery. When I examined her, I realized that she had significant upper motor neuron signs, and so I have to send her back for an MRI, whole spine screening, and I realized that she had a significant cervical problem also that requires surgery. So the first and foremost message that I want to give you is clinical evaluation is a must before you go for a spine MRI. MRI is a tool that can help you to reach diagnosis, provided you use it in tandem along with clinical evaluation and other investigations. So with this thought, let me start my today's talk on how to read MRI of spine. Myself, Dr. Ravish Patel, consultant spine surgeon from Vadodara. Reading spine MRI doesn't mean reading at the MRI report. It actually means is to examine a patient and correlate your findings on the radiology and try to match significant and important findings. The spine MRI has an advantage that you can visualize bones, disc, neural tissue, ligament, and vascular structures, and it is a radiation-free evaluation for the patient. So what are the views of spine MRI? First and foremost, you should look at the sagittal view. That is, you are looking at the spine from the side. The next is axial view. It is basically a cut section or the cross section of spine at different level. And then the third is a coronal view, wherein you are visualizing spine from the front. So the main sequences that we see on a spine MRI are T2 and T1 weighted sequences. Sometimes we also look for fat suppressed the stir sequence and post contrast sequences and diffusion weighted sequences also. So about the main two sequences, that is the T1 and T2 weighted image, the main difference is how it visualizes water or any fluid in the body. So on the left hand side, you can see a T1 weighted image where the red arrow shows CSF, which is dull in color, whereas on the right hand side, you can see the T2 weighted image where the CSF is very bright. The white color is CSF. The first and the foremost image that you should see is a screening spine MRI. And one should make a habit of ordering a whole spine screening along with a dedicated study of the region that they want to visualize. So if you look at the T2 weighted sagittal screening MRI, the structures that you can see include brain, lower portion of the brain, cervical spine, thoracic spine, lumbar spine, and sacrum. It is important to note that the spinal cord ends at L1, and after that there will be nerve roots which will be traveling through the lumbar and the sacral region. So this is the T2 weighted sagittal image. That is the first image that we should see. Counting is always done from the top, and that's why you can see sometimes variations. Sometimes alpha is sacralized, sometimes S1 is lumbarized. In this T2 weighted sagittal image, the main identification point is the bright color of the CSF that you can see. And other structures that can be visualized in this T2 weighted sagittal image are vertebral body, which are of intermediate intensity. The disc in between the bodies are bright in color when they are hydrated or a young healthy disc. When they start to degenerate, they become black in color as seen on the left hand side cervical spine images. The spinal cord is of low intensity in T2 weighted sagittal image. And when we go for the parasagittal cuts, you can see the nerve roots coming out through the foramen. The next, we should move on to the T2 weighted axial image. Here you can see the dural sac, again characterized by the bright white color. In the cervical spine, you will be able to see a spinal cord. In the lumbar spine, you will be able to see the nerve roots. The structure anterior to the dural sac is the disc in this cut section. And posterolaterally, there will be two facet joints, which can be seen in cervical as well as lumbar spine. And you can see traversing and exiting nerve roots coming out through foramen at different level in this section also. So what are the common pathologies for which we use T2 weighted sequence? The very popular and the most common is a lumbar disc herniation. You can see on the left hand side is a normal MRI. On the right hand side is a herniated disc, which is shown with a red arrow. You can see the dural sac, which was free in a normal MRI, is totally occluded by the herniated disc on the right hand side images. Similarly, you can see a lumbar canal stenosis. So on left hand side, the nerve roots are free inside the dural sac. On the right hand side, because of the disc, because of the ligament flavum hypertrophy, because of facet arthritis, there is a significant narrowing and compression on this nerve roots. Similarly, cervical spine stenosis due to an osteophyte disc complex or an ossified ligament can be very well visualized on an MRI. When we go for a evaluation of spine trauma, we can definitely identify fracture dislocation on an X-ray or a CT scan. But what these images won't tell you is why is this patient having paraplegia or paraparesis. So it can be visualized on an MRI where you can see a significant bone piece hitting on the nerve roots, and that can only be identified with an MRI. Similarly, many ligamentous injury cannot be visualized on an X-ray or a CT scan. Sometimes hematoma or a disc herniations may be causing a spinal cord compression and may not be visualized on an X-ray. And sometimes the patient may have occult injuries, so their X-ray and CT scan is normal, but MRI will show a pre-existing stenosis with a whiplash injury giving rise to a cord edema, as you can see in this image with a red arrow. So now moving forward to T1 weighted images. You can see in this image, majority of structures are dull in color, except the vertebral body. Because of the fatty marrow tissue, it is bright. The disc, the spinal cord, and the CSF, they are dull in color. T1 weighted images are good images to visualize the foramen, that you can nicely see the nerve roots coming out through the foramen. And T1 weighted axial images also shows the low intensity signal of disc, dural sac, and the facet joints. So T1 weighted sequence is important because normally the fatty tissue, the fatty marrow tissue will get replaced by a low intensity signal in case of an infection or in case of a tumor or by a bone edema following a fracture. Of course, many times we need additional investigations to differentiate between this, but the classical finding is that whenever marrow destruction is there, it will become dull in intensity on T1 weighted image. We also go for a stir sequence, which are fat suppressed sequences, and since they are fat suppressed, they will highlight fluid in the body. So it is a good sequence to visualize pus or an abscess formation in case of an infection. And sometimes it is also useful to identify the fresh and differentiate between the new and the old fractures. So if you see in this image, you can see that the fractures marked with red arrow are new one because I can identify on the stir coronal image that they are bright in color, whereas the fractures with a white arrow don't show any stir hyperintensity. So they are old fracture. So that is an old fracture. Post-contrast sequences are important when we want to differentiate a vascular from an avascular tissue. So epidural scarring is not vascular, it won't light up, whereas a recurrent disc herniation will light up. Abscess again will show a peripheral enhancement with a central hypointense signal, whereas tumor, which is a highly vascular structure, will show hyperintense signal on post-contrast sequences. There are few drawbacks of MRI as well. You cannot see a dynamic change in spine MRI. So in this image, you can see degenerative changes in lumbar spine, but no other pathology. But when we go for a flexion extension view, you can actually see a vertebral body moving forward and backward. So listhesis or an instability cannot be visualized always on a spine MRI. There can be a problem of overdiagnosis because if you screen 100 normal people, 50% will have some of the other degenerative change. So it is very important to correlate your findings clinically. And third, it is a two-dimensional study, unlike a CT scan. So I would like to end with the take-home message that always correlate your MRI with the clinical picture. Always ask for a screening of whole spine when you are asking or when you are getting a detailed study of an affected region. T2 weighted images are the key images for evaluation of most of the spine pathologies, and T1 weighted images are useful for infection, trauma, and tumor.
Thank you, Ravish. That was a very extremely good lecture. Dr. Vibhakar, I think we have 10 minutes now for discussion, and I would like to shoot off the first question to you as a general practitioner. I think you're a pediatrician, sir. How often do you examine your patients for backache or spine pathologies yourself, and how often do you send them off straight away to an orthopedic or a spine surgeon?
Backache is always a very common symptom that we come across, and we try to analyze various aspects, including the posture of a working man or a woman, and that happens to be perhaps amongst the commonest symptom and the causative factor in evaluating a back pain. And by majority of the cases, if there are no root pains or shooting pains and things like that, we try to go into the posture and correct that posture, and give maybe analgesics for a few days and wait and watch. If things don't improve with that, then perhaps we go for further evaluation starting from X-ray.
I would like to invite questions from all the participants also. Gautam, do you have anything to say?
Some questions from participants who are watching us on the YouTube platform, on the platform, online platform. Dr. Kelkar has a question for Dr. Jwalant Patel. How do you differentiate? A lot of patients with cervical spondylosis, when you examine them, also complain of shoulder pain. How do you differentiate whether the problem is from cervical spondylosis or is it a shoulder pathology? Jwalant?
So sometimes we have to evaluate and differentiate between the cervical pathology and shoulder pathology. And there are certain specific cases, as I mentioned in my lecture, that cervical pathology due to disc herniation or cervical spondylosis at specific level lead to the cervical radiculopathy in specific myotome and dermatome with associated pain, weakness, or reflex changes in that particular specific dermatome. However, the shoulder pathology will lead to the shoulder pain, stiffness, and that is not associated with specific dermatome. Patient may complain of diffuse kind of pain with mechanical of activity related pain in shoulder, and there are certain specific tests like Sperling maneuver, shoulder abduction relief sign. From that you can differentiate between the shoulder pathology and cervical pathology.
Thank you. I would just like to add, for the benefit of Dr. Kelkar and others, that usually when the pathology is in the neck and it is causing a compression of the nerve down, the pain goes down the arm, there is no localized tenderness over the shoulder. When you examine and you find localized shoulder tenderness, or you find a restricted range of motion of the shoulder, especially internal or external rotation of the shoulder, this generally it seems to suggest that there is also a shoulder pathology. Thank you, Jwalant. There is one more question also for you from Dr. Doshi from Bombay, and Dr. Atul Doshi asked you a question as to how do you, the same similar kind of question, how do you differentiate between sacroiliac joint pathology and a spine pathology?
So as I have already mentioned in my lecture that there are certain tests for sacroiliac joint as well, like Faber test or figure of 4 test. And sometimes the sacroiliac joints is associated with spondyloarthropathy. So you may have multiple joints pain or other associated morning stiffness or like that symptoms. And pain of lumbar spondylolisthesis or spondylolysis is associated with specific dermatomal pattern. You have to note the radiculopathy, you have to note the claudication and SLR, as well as the certain specific test for sacroiliac joint, pump handle test. From that you can evaluate and differentiate between the sacroiliac joint and lumbar pathologies.
Right, thank you. Should I continue, Rushma? There are a bunch of questions, or would you like to?
Yeah, please do. I think that is the whole purpose of the webinar, is to have the questions answered.
Yes. This is from Dr. Mohinder Kaushal. He is from Chandigarh, and his question is to Dr. Hitesh Modi. Dr. Modi, regarding a lot of patients, when we do an X-ray of the neck, they show the X-ray report comes as cervical spondylosis, and this patient has mild to moderate neck pain, which has been there off and on. And how much importance should we give to this X-ray finding of cervical spondylosis, and in which case, what sort of treatment should we start to these patients who are coming with mild to moderate pain?
Thank you, Dr. Mohinder, for a question. That cervical spondylosis is basically a very common condition. If the patient's age is more than 35, 40, I think they used to start having cervical spondylosis. And if we get an X-ray, we can see some sort of osteophyte formation in X-rays. So basically the treatment for cervical spondylosis, if the patient does not suffer from any kind of neurological sign or symptoms, and the pain in neck associated with some sort of spasm, or maybe during day-to-day, if the patient is working for a long time on computer, or maybe for surgeon like us, they develop this kind of neck pain due to cervical spondylosis. The first line of treatment for cervical spondylosis is basically, first of all, reassurance that there is nothing wrong. Additionally, we can advise some sort of routine physiotherapy like isometric neck exercise, as well as strengthening exercise for the neck muscles. If patient's pain does not improve, then again, we may go for further investigations like MRI or other things. Thank you.
One more question for you, Dr. Modi, and that is from Dr. Rao from Hyderabad. Dr. Rao has put this question that how, if a patient comes to us with generalized acute low back pain, what should be a trigger for doing X-rays in such patient? If the patient says that I have been having some little low back pain for last 7 to 8 days, and then it has become worse since 2 days. When should we order? Should we order an X-ray immediately, or should we wait a little bit time, start treatment, and then do an X-ray? What should be the protocol?
This is very common scenario during our clinical practice, that usually most of the patients present to us in OPD are having little bit of back pain since long, and suddenly it gets worse. And if you see clinically them walking in OPD, they walk like with a spastic gait or barely walk. They put their hand on one leg to support themselves. This kind of condition is very common. And first of all, the clinical examination of such patient is very necessary to identify whether there is any associated spasm in paravertebral muscles or not. We have to examine in terms of SLR. And then if patient is in severe pain, we can analyze them and give them a muscle relaxant or injectable analgesics, and we can get his X-ray. I know most of the time X-ray may come normal, but if patient is having acute back pain over a period of long-term chronic back pain, we may find something else. So it is better to get an X-ray in AP and lateral film. I would try to avoid flexion extension or movement X-rays at this moment. Only I will stick to AP and lateral view, and depending upon further guideline on X-ray, I will go for further investigations.
Dr. Menon from Trivandrum asks you, how do I diagnose osteoporosis on plain X-rays?
Diagnosis osteoporosis on plain X-ray. Basically from spine X-ray, we have to remember that the density of the disc is very low compared to the vertebra. And if the density of the disc and vertebra are coming to closer and closer, then I think it may indicate osteoporosis. But I think we must remember that we have to involve wrist as well as hip joint X-rays to identify the osteoporosis. And the ideal investigations to to diagnose osteoporosis is getting DEXA scan if you suspect on a spinal X-ray.
Right. Thank you very much, Dr. Modi. Last two questions are for Dr. Ravish. This is question from Dr. Gwalani. She says, congratulations on a fantastic lecture. And the question is that often we see patients who come to our clinic with severe acute back pain. And when we do an MRI, the MRI is reported as essentially normal. How do we explain the back pain in such patients?
Okay, thank you very much for the question. As you mentioned, that this is a very common scenario, that when a patient comes to us in our clinic with a severe back pain and the MRI turns normal, in most of the cases, when the MRI is normal and the patient is having severe back pain, it is secondary to an acute muscle spasm, which has occurred after a sudden bending forward or sudden jerky movement, and which has caused a muscle sprain. And this is a very common scenario. And the good thing is that most of these patients, they get better with conservative care. And so I think it is very important to tell them, reassure them that your spine is normal and that this acute pain will settle down as soon as the muscle strain heals.
Another question is from Iyer. He is from Trichy. And he has asked you that sometimes we find that in a patient with acute disc prolapse, the orthopedic surgeon says the disc is actually very small in size, but patient has very severe pain. And on the other hand, sometimes the disc is very large, but the patient doesn't have much pain. How do you explain that?
Yeah, so that's a very good question. First of all, I would like to make a statement that the size of the disc does not indicate the severity of symptoms. This is because the location of the disc herniation and the stage where we see a patient is also very important. Sometimes a central herniation, large central herniations can be well tolerated, but whereas even a small foraminal herniation or even a small extraforaminal disc herniation will be very painful. So one is that it depends on the location. Second is that whenever there is a disc herniation in an acute stage, there will be an inflammation, and which will give rise to severe pain. Over a period of time, that inflammation component will settle down and the patient may get better. So it is very common to see in our clinical scenario that even a patient with large disc, they may not have any symptoms. And I think it is very important to guide the treatment based on the symptomatology rather than relying on their MRI alone in such patients.
Back to you, Dr. Advaryu and Dr. Ushma.
Yeah, so I think that I would like to summarize this session from my side, and that is that the first question I think which I would like to address is the cervical spondylosis. Cervical spondylosis is a very broad term which includes X-ray changes, clinical symptoms, and the whole scenario. So most of the radiologists they take the X-ray and they just say this is cervical spondylosis, but what exactly they mean by that has to be deduced by the surgeon himself or herself after examining the patient. So that is one thing. The second thing that was a very good question was that how do you diagnose osteoporosis on an X-ray? I think this question should be said once for all that in the age of digital X-rays, I don't think this is possible at all now, because the digital X-ray is adjusted by the radiologist to give you a good image and does not tell you anything about the density or the architecture of the bone clearly. Ravish, I think your presentation was really very nice and told us everything about the imaging. And I think we can wind up this session. Gautam, if you say so. Dr. Vibhakar, would you like to say something?
Yeah, from the general practitioner's point of view, this session was very important to tell us about the basics of clinical for anatomy, clinical evaluation, as well as the imaging modality. I think we can move forward from here.
Thank you, Dr. Advaryu.
Thank you,
Thank you, Dr. That was a wonderful, and I would like to thank the speakers of the session, Dr. Gurdip, Dr. Jwalant Patel, Dr. Ravish Patel, and Dr. Hitesh Modi for providing us with great insights into the basics of spinal problems